all of us are facing this challenge of accommodation in refraction. Not that accommodation and convergence was not there years before, but the challenge that we are finding that it is practically a problem or an issue that we are facing in refraction with almost every patient. The accommodation excess or even deficiencies and all these errors, you believe it or not, we have a lot of cylindricals that we see now, which we never used to see for years of our experience that we have. And these challenges are making it very difficult for LASIK surgeries, prescription of glasses, which is making a problem for patients in adaptation, or rather inducing myopia in many more.
What are we talking about when we say accommodative challenges in refraction? What is accommodation, first of all? Accommodation basically is the ability of your eye to focus at different distances, be it something which is more than 20 feet away, something which is 40 centimeters from you, something which is in between, like my computer screen, for example, which is at about almost a meter away from me right now. So what happens in accommodation is basically there is a change in the shape of the crystalline lens, which is a biconvex structure, which is there in the eye. Your ciliary body contracts when anything is brought up close. Zonules relax. The lens becomes more plus, and then, it becomes more biconvex and therefore more plus. Okay, so this is the basic of accommodation. And what happens is sometimes when it becomes more biconvex, it sometimes is not able to relax completely. And when it doesn't relax completely, that is what we call as spasm of accommodation. So this is just a very quick recap of what accommodation is and what spasm of accommodation is. And this will sort of, take me forward in my talk right now. So what are the indications or what are the conditions or what are the situations where we need accommodation control? The first thing is, if you notice during your retinoscopy, I don't know how many of you are doing retinoscopy, but, I am a huge fan and an advocate of retinoscopy. One of the best techniques where you can pick up so many different lots of information, which will give you a guide to how to handle your patient. So if during retinoscopy, your reflexes are fluctuating from plus to minus or lower minus and then going to higher minus, higher plus to lower plus, that's when you know that the accommodation is really not under control and you need to do something regarding that. When you're checking vision before that itself, when you're checking vision and you find that the vision is varying, they're suddenly reading 660 and then they're suddenly sort of trying and reading and they're going on to read 612 and going back up to 660. Something is happening with their vision as well and their accommodation. In case of children, they don't particularly follow instructions. I mean, if any of you have worked with young children who are about 3 and 4 years old, they're easily distracted. So they're not going to look at your distance target when you're sort of asking them to look at the retinoscopy for the screen, for the distance vision. So what happens is at that stage, we need to figure out how we're going to control the, accommodation. Anybody who comes in with complaints of asthenopia, which include headache, eye strain, brow ache, difficulty with reading, letters jumping, distance blurring up once they're reading for a while, better to figure out what we're going to do with their accommodation as well. Any patient who comes with ocular deviations, especially esotropia, you will definitely need to look for what is happening with their accommodation. And if at all you feel that the patient has been over-minused, so they come into you and you feel that the glasses that they're wearing, like I had a patient today morning who's wearing a minus 1.5 in both eyes, but retinoscopy is showing me nothing more than 0.5. And the patient is extremely happy with a minus 1.5. But now after probing, she said, I'm getting a little bit of headache. So when you think that this patient has been over-minused, you have to start working on the accommodation, you have to figure out how to control it. Any hyperopic patient will have accommodation, and their accommodation is very active, especially when they're very young. So these patients also you have to work on control. Lead of accommodation, I'll quickly go through MEM at one point, where if you start seeing minus instead of plus when you're doing MEM, then you need to figure out what you need to do with accommodation. When I said esotropic patients, any ESO patient, and when you're doing your retinoscopy, if you see the pupil constricting and then constricting again and going back in and out of that, then you know that the triad of accommodation, convergence, and pupil constriction is happening. So you know something is happening with the accommodation and it is active over there. So again, you have to figure out how you're going to control the accommodation. So these are the various situations that I can think of where you will need to control the accommodation. Now that we know what we have to control and when we have to control, what are the methods of controlling the accommodation? The first method, whenever you're doing any objective kind of a refraction, is monitoring the fixation. Repeatedly instructing the patient to look at the distance, not look at your light, giving them a proper target to focus on. So that is something that you will need to work on. I've noticed a lot of people, the trainees especially, will just switch the light on and say, look at the light on the chart. Please don't do that. I'll just, in the further slides, I'll just quickly explain all these things as well. The other option of controlling accommodation is by the addition of plus lenses optically or by the usage of cycloplegic drugs. Okay. So the fixation monitoring and instructions was the one that I was talking to you about first. Now you have to make sure that you're sitting at the correct position when you're doing retinoscopy. So I normally work at about 67 centimeters, which translates into a working distance of plus 1.5. Now the target which needs to be given should be a non-accommodative target, which is at least about 20 feet away from you. So I normally ask them to look at the duochrome chart, and I ask them to look at the green target, which is over there. Now this is one way of controlling the accommodation. The other way that you have to remember is, if you are working at 67 centimeters, you've put a working distance lens of plus 1.5 diopters. Now that plus 1.5 diopters itself could act as a fogging lens and control the accommodation. Important, remember to maintain your working distance all through the procedure, and do the right eye with the right eye and the left eye with the left eye. Now, the reason why we repeatedly say do right with right and left with left is basically because when you're doing the right eye with the right eye, you're not blocking the other eye. If you're sitting in front like this and doing it, you are blocking the patient's view, and therefore the patient is going to look at what is right in front of them, not over and above your head, right? So make sure that you sit away and sit exactly in front of the right eye when you're doing the right eye, and do it with your right eye. Move to the left, do it with your left eye whenever you're doing your work. So this is basically fixation monitoring and the instructions that you will need to give. Repeatedly ask the patient if they're able to see the target. And sometimes I get them, if it is young kids, I flip the charts and say, is it letters, is it numbers, is it pictures? So I know that they're really looking at the chart. Okay. Again, so this is right with right. So this is what I was trying to tell you about the dynamic retinoscopy or near retinoscopy, where the accommodation is completely active and the patient is looking at your target at 40 centimeters. The near working distance, I normally ask them to look at 40 centimeters because that is comfortable, and I know it translates to plus 2.5. Patient views the target with both eyes open, so their accommodation and convergence is working, but their convergence is kept fixed at that 40 centimeters, so you do not move the target back and forth away from the 40 centimeters. Then you figure out whether you're seeing a plus, a with movement, or an against movement with the retinoscope in the plane mirror mode. Okay. Now, if you see plus, which is what you expect. Now, like the human beings, the body also is pretty much what we are, right? It will do only what is absolutely essential and not a little bit more. So if I'm supposed to be working at 40 centimeters, my eye should accommodate by about 2.5 diopters to see something clearly. Now, most of the time, it doesn't really accommodate 2.5 diopters. It will accommodate a little less, so about 2 diopters. So the remnant 0.5 diopter that you see, you will see as plus with reflex, which you will see in the lead of accommodation is when the over-enthusiastic few of us, the eye accommodates over and above the distance that they are focusing at, and you will see a negative reflex, okay? So a negative, a minus, when you see an against reflex and you're putting minus lenses to neutralize, then you know that the person's accommodation is over and above what is required and therefore needs to be looked at, okay? So this is basically what that is, and I just explain all this to you. So the next option is cycloplegic refraction or wet refraction, as we sometimes call it. Drugs are used to temporarily paralyze the accommodation. The pupil will be dilated, and the drugs that we normally use are cyclopentolate, homotropine, or atropine. Now, this was one of the favorite questions, my professor used to ask me when I was in college. How do you know if cycloplegia has set in? So what most of us do, me included, I'm guilty of this as well. So I put the first drop, 10 minutes, repeat the second drop in 10 minutes. So from the time I put the first drop, 10 minutes, another 10 minutes, another 10 minutes. So it's half an hour. I just start doing the retinoscopy. And when I do the retinoscopy, if I find that the refraction value is changing, then I know that the cycloplegia has not set in. But I don't want to be making the patient, sit the patient on the retinoscope and then say that, the cycloplegia has set in or not. So what I was taught is put a +3 diopter lens. Now, if the accommodation is temporarily paralyzed, when I put a +3 diopter lens, I should be able to see any near target only at 33 centimeters or longer than that. Now, if I'm able to see the target clearly, even closer than 33 centimeters, then I know that paralysis or the accommodation is not set and the cycloplegia has not set in, right? So then I need to wait for a little longer, repeat this before I actually do the retinoscopy, okay? So if you have any questions on this, just put it in the chat box. We can discuss this a little later. So this is what you have to do. 3 diopter lens, target at 33 centimeters should be clear. But if it is clearer at closer distances, then wait for a little bit more and then review and redo the retinoscopy. Okay. Just a little bit of a pointer. You normally put cycloplegic refraction only under the supervision of an ophthalmologist if you are an optometrist. We are asking for in-clinic use rights of at least a few cycloplegic drugs. So hopefully that will also be part of our, authorization once we get our registration. So these are the common conditions where you would do cycloplegic refraction. In the case sheet, you have to make sure you time, sign, and you mention each eye, and you mention the sphere, the cylinder, and the axis. So for example, I would mention something like this. Now, this is what I get as I do retinoscopy. But with the drug correction, say I'm using cyclopentolate, I use +0.5 as the drug correction. This is what my prescription would be as the wet refraction, okay? Only the sphere changes. You don't do any alteration in the cylinder. You just do this and you get on with it. So this is as far as objective refraction is concerned. In subjective refraction, there are 3 things that I normally do in terms of keeping the accommodation in control. The first thing is you can start off with the objective refraction value with the working distance lens in place. So you start off, say I get a +1 and my working distance is +1.5. I start with the +2.5 and I slowly defog monocularly, one eye at a time. Now, when I say defog, there's one thing that you should absolutely remember. You have to slowly add the lower plus and only then remove the higher plus. Do not remove plus 1.5 and then put a plus 1.25. You've completely lost the accommodation control over there. So what you should do is, if I've put, say, like the example that I was telling you before, if there is a plus 2.5 diopter lens in place, what I would do is put a plus 2.25, then take the 2.5 diopter lens out. Okay, so that way we're still keeping the accommodation very much under control, and then keep on continuing until you get the best possible visual outcome. You will have to verify the endpoint for the sphere, then the cylinder, and then go back to the sphere again. Okay. Cylinder, you would have to do axis as well as the power verification before you go and do the sphere again. Now, normally defogging from plus 1.5 diopters works well in patients who have fairly normal accommodation and their accommodation is not overactive or they're not very young children. But in case of very young children or people with over excess accommodation, you could do something called the Borish delayed subjective test. Now, how you would do this, basically what we're trying to do is relax the accommodation as much as possible so that we can prescribe a higher plus lens than what the patient is accepting in the normal subjective defogging that you have done so far. So you do the objective refraction, you do the subjective with regular fogging, then over the acceptance that they've had. So for example, I've got a retinoscopy value of +1. I do the fogging, defogging, patient accepts +0.5. Now, at that stage, give +0.5 in both eyes, binocularly do the NRA, and keep, you know how to do the negative relative accommodation, isn't it? You add positive lenses, 0.25 diopters at a time with a near target at 40 centimeters. And once the patient says, no, this is blurred, I can't read anymore, you know you've hit the NRA value. Now, the NRA typically is between 2 and 2.5 diopters. But if you find that the NRA is exceeding this value, so instead of a +2.5, this patient is still saying things are clear with 3.25, then you know they're either undercorrected by that +0.75 if they're hyperopes, or the minus has been given more before and therefore it has to be reduced finally when you do the subjective. Once you do this, then binocularly you defog this patient looking at the distance chart slowly, 0.25 diopters at a time to give you the final prescription. So this is your basic Borish delayed test. Now the next thing that you could also do is something called the modified test where, for example, the cycloret value is +1.5 and the patient has come to you for a post-cycloplegic test. Now, lots of people call it the post-mydriatic test. It's not dilation test that we're doing. It's a cyclopost that we're doing, right? So I like to call it the PCT or the post-cycloplegic test where I then do the NRA. Now, I could do the NRA or going by the fact that most people NRA is 2 to 2.5 diopters for a 40 centimeter working distance, I would just put the 2.5 diopters and whatever refraction value I got, the retinoscopy value I got in the cycloplegic, which is a +1.5. So in this example, I've given you +1.5 as my cycloret. And to that, I add a +2.5 diopters. So I put a +4 diopters in front of the patient's eyes. I make them read for 30 minutes, a target which is at 40 centimeters, okay? Because we are thinking NRA at 40 centimeters, 2.5 diopters. So the target is kept at 40 centimeters and the patient is made to read with the +4 for 30 minutes. Now, basically what we're trying to do is relax the accommodation to the maximum as possible. And then once we are happy with them reading at 30 centimeters. Don't allow them to start reading much closer. So you will have to monitor the 40 centimeter distance. If they read any closer, then their accommodation is going to start kicking in. Okay. So then defog slowly for the patient, looking at the distance chart to read 6.6. And remember, put the lower plus in before taking the higher plus out. So that's basically the different kind of accommodation control mechanisms that we have and things that we can actually try. So I think at this point, I'm going to ask if Monica ma'am and Anita ma'am would join me in these case discussions. I'll just quickly brief the case and then if we could take the discussion forward, ma'am. So this is a case of a 15-year-old. Most of them come in with, especially just before exams, boards. If you have noticed, they'll come in complaining headache while reading and they're not able to see distance clearly. Now, this child came in saying distance is blurred after about 20 minutes of reading continuously. Initially, it used to clear up within 5 to 10 minutes, but now it's taking 15 to 20 minutes. And off late, in the last 1 week, he says he's just not able to see the scroll on the TV at all. So this was what he came in with, okay? And this was the values. His vision unaided was 660 in both eyes, but auto-ref value was giving me a minus 5.5. The red was giving a minus 5.5 in the right eye and a minus 4.5 diopters in the left eye, and I had varying reflexes. So at one point it was going absolutely down, and one point it was going all the way up to about minus 8 and 9. So this is typically one of those cases where you would need to think in terms of accommodation control. Now, subjective was done in the patient with minus 4.5 in the right eye and 3.75 in the left eye, read 6.6. Now, if you really go back to your basics, 660 to 6.6, now count the number of lines with me. So it's 636, 24, 18, 12, 9, and then 6.6. So you're looking at only 6 lines. 0.25 diopters for each should give you only a 1.5 diopter. But this patient required 4.5 diopters and 3.75 diopters to read. So, you know, if you guys can answer in the chat or anything, yeah, I've already got an answer. There's somebody who is saying accommodative spasm in the chat. So this was what the cycloplegic value was. Okay. Went all the way to plus 0.5 with a little cylinder in both eyes with the AR, but retinoscopy showed plus 1.25 with minus 0.25. So can you notice that there is a difference in the AR post-cycloplegic and the RET post-cycloplegic? Now that itself is another indication that you have to look at to see that accommodation is really not being controlled at all. Because when they're showing a lower plus in AR and a higher plus in your retinoscope, it's basically because again, AR is something which is up close. So even though we say, look at the target, which is like a long road and the house at the end of it, they're not really processing all that in their mind, right? So this again shows that the accommodation is really not under control. And the acceptance in cycloplegic was plus 1 diopters. Patient was reading 6.6. So all the way from minus 5.5, it went to plus 1 diopter. So this is one case where, yes, definitely using a cycloplegic drop would make a difference. Okay. So what do you think the next plan of action would be or should be? As much as atropine, homotropine, cyclopentolate all sounds great, we are really not allowed to do prescription at the moment. So I would hold back from doing things which are out of our lane. So in our lane, there's a lot of stuff that we can do. So let's try that first. I would definitely want to verify my prescription before I actually gave it to them. And I would explain why I want to verify the prescription. Okay. So this is what happened. I reviewed the patient again after 4 days, advising a PMT. I've written PMT here, though I would like to call it a post-cycloplegic test, because everybody understands PMT more than PCT. So I put PMT here specifically. Retinoscopy showed me plus 0.5 at this stage, though AR was still showing a very high minus. Okay. Fogging from plus 1.5 diopters, patient read 6.6 with plano because the vision was 6.6, right? But considering the previous history where the refraction changed from minus 5.5 to plus 1, and the patient said that he had difficulty with blurring of distance vision after reading for a little while, what I really felt was I should see whether I can push a little plus. So that's when I did the Borish delayed subjective. Patient accepted plus 0.75 in both eyes. And I have a habit of doing an adaptation test in the clinic. So I put the lenses in the trial frame and make them sit outside in the clinic. It looks hideous. It looks funny, but you know, it's okay because you don't want them to go and spend buying a huge, you know, expense on buying a lot on the top lenses, frames, and then coming back and telling you within a week that they're not adapting. So I put him with this in the waiting hall for almost about 15 minutes, after which he said, looks absolutely fine. He's able to read, he's able to look in the distance, and things are still looking clear. And we actually prescribed plus 0.75 for both eyes. Now, this patient I saw almost a year ago, and he's been coming for regular follow-ups. He's now gone to a plus 1.25 at the moment. He's still wearing the glasses. He came in when he was doing his 10th board exams. So he's still, sort of doing a lot of studying at the moment. And he's on plus 1.25 during the last visit. Okay. Patient had come for a second opinion for refractive surgery. We don't do refractive surgery, but it was somebody known. So they had come to see us for a second opinion. And patient was wearing a -2. Like you said, it would have been an absolute disaster if they had gone through refractive surgery because the refraction was actually plus 0.25. So first things first, the father-in-law was extremely happy because I had just saved him about 3 lakhs of rupees. But the girl was extremely thrilled because she said, yes, they had a test and they were advised refractive surgery and they were referred for refractive surgery. But then somewhere she said, I could see without my glasses, so I had a doubt. So luckily, since the patient was aware, it was saved.
Yeah, so it appears that the final prescription that you gave was a plus 0.75. Now, how readily are these children with accommodative spasm accept these? Though we do give some kind of, reading time in your clinical practice, a half an hour or 45 minutes, but they do not readily accept that. Many children refuse to take that. So how do you handle such situations?
So normally what we tell them is start using it when you're reading. So when they start reading with these glasses, the strain is reduced on the eye, and they find that comfort level is much more, and they're able to read for a much longer time with the glasses on than without. So once they start using it, they look up, they see everything is clear. Typical habits, we don't normally tend to take our glasses off, put it away, and then walk. If it's clear, I just walk with my glasses. So, it takes a little time, but we normally start off telling them to use it for close work first. All sorts of reading and looking at the book, writing and doing your homework and screens especially. And once they do that, within a week, they generally tend to settle very well with these glasses. So we do follow-up calls.
In fact, one more thing, the history. If you find a young adult or a teenager reporting sudden blurring of vision and a prescription being high minus, usually it's not the case. There is always a gradual progression, and the history onset is a very good clue for all of us to know this could be a spasm of accommodation also. Very importantly, in fact, yesterday only we had a patient coming back as a reject in some medical examination, and he had come back for some orthokeratology or some solution. So he was reported 618, 624 vision with high minus prescription somewhere or wherever he had tried. He was literally almost emetropic. And that's history was last 2-3 months. Of course, I started feeling, but when he went for a medical examination, or he was actually preparing for his exams these days, and he was emetropic. And only thing we had to do was cycloplegic refraction. And we need to go vision therapy, as all of you in the chat had also suggested, is also one of the way forward to help these patients.
Also, ma'am, you mentioned about history, the importance of history taking. So recent illness also should be asked for.
Very important part.
So that's very, very important. Like, you know, for us as eye care practitioners, history gives you a lot of clues. Your diagnosis happens if you have taken a very good history itself. So any recent illness also should be stressed upon, because that also the child lands up with an accommodative spasm. In many cases, it would be a positive when you ask for any recent illness.
Now, spasm of accommodation cases, if you've really seen, they generally don't have much issues with near vision, because they're basically, if you look at the minus 5.5, he's an uncorrected myope, right? And an uncorrected myope generally will hold things a little closer to see things. That's it. And they would get on with it. They would start here and then keep going closer as the prescription, the spasm is increasing. And then they will keep telling you that, you know, I'm bringing, if you ask for the history, you will notice that they're bringing things closer to read and distance is not clear. You know, so usually they don't have much issues with near vision. So a 5-year-old child who was previously diagnosed as esophagic, the parents noticed that the child has become more cross-eyed, especially after she started school and when she's looking at things close up, books or toys or anything like that. But she didn't really have any problems with vision, happy playing, doing everything else. History was otherwise insignificant. And this was her unaided vision. So she had 6.6 N6 in both eyes. The autoref gave us a plus 0.5, which in itself is an indicator that this child has a hyperopic error. Now, retinoscopy gave us values close to plus 2 and plus 1.5 diopters. The cycloplegic subjective with 1.5 diopters in both eyes, she was able to read 6.6 comfortably, both monocularly as well as binocularly, and N6 as well. Cycloplegic showed only a plus 1.75 in both eyes, and we actually gave her the final prescription as plus 1.5 diopters. Now, as with anybody, as with any parent, when we tell them that, you know, they have to wear glasses for the first time, they didn't want to hear that. They wanted to know whether there were other options. Why should we give them a plus 1.5, which sounded like a huge number? Why should we even give that? Because the AR value showed only plus 0.5. Now they went in for a second opinion and she was prescribed plus 0.5. Week later, they came back panicking, saying that after she started wearing the glasses, the squint is increased. But what, there was a small, I'll just tell you what happened afterwards. So what do you do next? There's a couple of learnings in this, which I think is very practical, especially if you're doing a lot of training and you have trainees. What would you do next? So I prescribed plus 1.5, okay? Patient went out, got a second opinion, got glasses made elsewhere, and then came back to me complaining that ever since I suggested glasses, the squinting has increased. What is your first reaction? Eye turning in. There was a question here whether it is squinting ESO or EXO. It's an ESO. As I mentioned, esophoric becoming more frequency of squinting inside. So what happened was a couple of things, okay? The two learnings that I was telling you about. One was definitely, you know, one of my students saw this patient first. they basically looked at my final prescription, which was plus 1.5. And what they failed to do was check the power of the glasses that the patient was wearing. Okay. So they went for a second opinion. They thought the patient had just got some new glasses outside and come back. So they didn't know it was only plus 0.5. So they put the plus 1.5, which was my prescription, and did a cover test. There was no movement. So then they got confused. So then, you know, there was this whole discussion forum which was going on. And then they brought it to me and I said, did you check the prescription of the glasses? On probing, we found that this patient had gone outside for a second opinion. Somebody had said, such a young child, plus 0.5 is enough, and prescribed the plus 0.5 based on the AR value, which I suspect based on the AR value. Now, basically what happens is when the patient is esophoric, there is some amount of, you know, divergence that happens and some amount of control that is there. You're relaxing a little bit, which makes the eye converge even more to accommodate for the extra plus 1. And that accommodative convergence increases the appearance of the squint or the frequency of the squint. Okay. So like everybody, like a couple of answers that we got, we did give the full correction. We did suggest vision hygiene, you know, good lighting, reading in good light, reading at the correct distance. Vision therapy was also suggested. We did give them heart chart. We did accommodative rock, explained everything to them and sent them home. So the learning in this is a couple of things. First of all, check the power of the glasses when it comes back to you. Maybe I should not have mentioned was prescribed 0.5. I should have just said, went for a second opinion, but came back with complaints of increased frequency of squinting. Then, you know, that is something that we should really think about. Okay.
In a similar case, I would like to discuss that it's now my third patient in last 1 month. In COVID, the children, especially born in 2019 or 2020. So the first 4 or 5 years of their life, they have been only indoors and they have learned to be indoors. They were given these screens, even the KG or a nursery student was. So the whole development of accommodation and convergence, I don't know if we'll come across with reports also globally coming in. We're finding the emetropization, the whole process of development of the accommodation and convergence is totally going
all messed up.
And this child has been going across with unusual pattern of convergent squint seen and is turning out emetrope. Right from one state to other, they have been going for this convergence and accommodative convergence which this child is having. Refraction is emetropic. And on finding, we get to know the child is too much indoor, grandmother taking care, again indoor, daycare center taking care, again indoor, first 3 years of life indoors. So the child in early stages, as should have been playful outdoors, we are seeing certain squints which have been just manifested as the abnormal AC by A ratios, and we have to work on it. And this is my of course, this third child of this age that I have seen in past few months.
So this is something that has to be really looked into now.
We are trying to report, and you know, there were prescriptions of atropine to relax the eye. There was home atropine also by given, because there's no plus prescription, not even a 0.25, 0.5 for this child. So we considered it as an accommodative convergent squint. And now what plus do we prescribe? So the previous examinations when this child came across was that is not having any plus prescriptions. So how do we work into it? And a 4-year or a 5-year-old, how do you do the vision therapies and explaining them, divergence and explaining? Now, the only thing we did was take the child outdoors. And mother started reporting within 10 days saying that, yes, I see the squint going less. And stop all digital screen, mobile use, near toys and everything for the child for some time.
Digital use, especially with children now, is becoming such a problem most working parents want that 10 minutes to sit down, so they put them in front of the screen. So it's like
also feeding cranky children,
Yeah.
hold the mobile, show them some cartoon or whatever, and then feed them. So that's very popular, right?
So what our process is normally, whenever one of us sees and decides that a cycloplegic refraction is required, the first thing is we discuss the whole process of what a cycloplegic is with the parent. So we tell them that there is the eye muscles are working more than what they should in that age. If it is a younger child, if it is an adult, we normally talk to them and we tell them, like, your muscles are active, extremely active at the moment, and we're not able to arrive at the exact prescription. So what we would like to do is give the muscles a rest. And once the muscles are at rest, we would then like to get the exact prescription out so we can finalize on what sort of glasses, the number that we should be prescribing to you. And then the process is with cycloplegic, any drops for that matter, we check whether they are allergic to any prescriptions, whether they've had any cycloplegic drops, or whether they've had any drops instilled in their eyes before, and whether they've had any allergic reactions. We've not had very many allergic reactions. Probably in the last so many years, a couple of patients have been allergic to cycloplenicillin. We actually see a lot of them being allergic to the Tropicacil Plus more than they are to the cycloplenicillin. We also warn the parents that the vision is going to be blurred anything up to 24 to 36 hours. Now, 36 hours is a little excess, I know, but usually it kind of settles within a day. The reason why we give them the 36 hours is each person's eye reacts differently, and each person's sensitivity to light is also very different. So some parents or children would complain of severe discomfort even with minimal photophobia, whereas others would settle down happily with, well-dilated pupils as well. So we normally give them 24 to 36 hours. The first drop is instilled once I finish this discussion in my room. Time is noted. 10 minutes from that, if it is anybody over the age of 15 or 18, it is 10 minutes after that. If it is a younger child, I normally say wait for 15 minutes and then instill the drop again. Okay. And then the second drop, after the second drop is instilled, 15 minutes from the second drop, we then, AR is done. But I also, AR is, like you were saying, AR is here to stay. Automated refractometers are here to stay. So you can't not do it. We just do the AR. And with the cycloplegic instilled, AR gives fairly decent values. Only when, again, please underline the word fairly decent. I wouldn't completely rely entirely on the AR value. We do retinoscopy for all patients that have to undergo a cycloplegic refraction. So once they do the retinoscopy, then we figure out what the differences are. And like I said, of late, we've also been noticing that the children, accommodation is not relaxing at all. So in those cases, we do the +3 test to check whether they're reading at 33 centimeters. If that is not happening, there have been cases where we've instilled a third drop and then seen the patient again after 15 minutes after the third drop as well. So that is a process that
the time duration and that +3 test is very important, or even the variation in the retinoscopy while you are doing your fine and the pupil constricting still. And these are very important tips, and just not rushing in. If there is, it's important even you can give that medicine to the parent and 2 times and then ask them to go and come back even after an hour and return back, so that you're sure that the duration of cycloplegia or the action has happened. It's very important from the first drop till the last. What is the time gap that you have taken?
Yeah. So that is why when I said when you document, you have to mention the time at which you're putting the first drop, and the time at which you're doing the second drop, and the time at which you're doing your refraction. So that gives you an idea as to whether you're in the frame where the cycloplegia has set in. So you're looking at a minimum of about half an hour after which the cycloplegia actually starts setting in and working. In case it is a spasm, and we notice that the cycloplegia it doesn't always break down this easily like in this particular case. But if it doesn't, then we prescribe atropine ointment. The ophthalmologist prescribes atropine ointment for home, and then they come back after 3 days. So when we're prescribing atropine ointment, that time we've had a few adverse reactions where they've developed a spike in temperature or they've suddenly become hyperactive and things like that. So you have to warn them of all the probable issues that they can face. I would very, very, very sincerely and strongly advocate against prescribing atropine without the supervision of an ophthalmologist, because there have been severe adverse reactions and you don't want to get into the wrong side of the legalities. So, please stay in our lane. That's something which I'm very, very particular about.
The first step towards achieving your dreams is having the right coach. Get the best education with Learn Beyond Vision and make your optometry dreams come true. Download the app now.